office, and I'm an orthodontist and researcher in the oral dental division right here at the National Research Center. I wanted to do another presentation, also related, but I was told that it has to be research oriented, and so I'm presenting the last publication that we did in the department. For over 2 centuries, dental students all over the world are taught that straight teeth give better oral health. If you have straight teeth, you are less likely to develop cavities, dental caries. Orthodontists pass from generation to generation what we know as the 14 sequela of untreated malocclusion, which means why orthodontists should treat dental malocclusion. Okay? At the top of that list, then, number 2, is the belief that dental crowding or dental irregularities will disrupt the contact between the teeth, and this will lead to accumulation of food debris and plaque, leading to the all-hated dental cavities. The belief is logic. If you don't brush well, you will have food accumulation, and in turn you will develop caries. But in our literature, there is no proof in the studies to support this belief. So we set out to find out, is dental crowding really a risk factor of developing dental caries? Why would this be important? In the field of orthodontics, or in health in general, we have 2 major problems. Ethics and money are always an issue. The ethical point is, can I, as an orthodontist, prescribe to my patients to do orthodontic treatment to relieve crowding just to prevent caries? And can I recommend to the insurance companies to include orthodontic treatment on that ground? So we started a systematic review, which, as we all know, is one of the highest evidence in medical literature, to assess the association between dental crowding and dental caries. We designed a search strategy to include all relevant articles, multiple electronic databases, manual searches, and personal contact of authors was performed, and we designed 4 criteria predetermined for the assessment of these articles. Our results showed that 18 observational studies met the inclusion criteria. Only 8 cross-section studies were eligible for assessment. The quality of these articles were assessed by the MOOS guidelines. And it showed that 7 of these studies were of moderate quality and only 1 had poor quality. We have 8 studies in all. 4 of them showed no association between dental crowding and caries, which was not expected. Even more surprising, 2 studies showed an inverse relationship, meaning that they found crowding to produce less caries. Only 1 study showed a positive association, where crowding increased the association of the incidence of dental caries. And 1 study was so controversial in itself that some areas showed an increased incidence with crowding, other areas showed a decrease in the incidence. And so the systematic review shows that there is no conclusive evidence to support or refute that dental crowding causes dental caries. Although we recommend treating crowding for better aesthetics, better tongue function, better speech, and oral functions in general, it is not valid to recommend treatment of orthodontics just to prevent dental caries. Thank you very much.
Good morning, everybody. Thank you, Dr. Jan, for giving me this opportunity My dear professors and colleagues, ladies and gentlemen, I'm Iman Ali Helwa. I work in the Immunogenetics Department. This is one of the departments of the Immunogenetics Division at the National Research Center. I come from Cairo, Egypt, of course. As most of us know, colorectal carcinoma is the third most common cause of death from cancer worldwide. And the surprising thing that most of the patients present with a surgically resectable disease. But the problem is most of these patients die afterwards from metastatic disease. How can this be explained? Actually, the only explanation for this finding is that the cancer cells have already spread and disseminated beyond the border of resection, even before the surgery has been done, but it couldn't be detected by the routine methods used for tumor staging. The aim of my study here was to assess metastasis, or maybe say micrometastasis, in cases of colorectal carcinoma based on a marker called cytokeratin 20. Why cytokeratin 20? Because it belongs to a family of musculoskeletal filaments, and actually cytokeratin 20 in particular is confined to the intestinal epithelium. It doesn't have any pseudogenes. It is not supposed to be found neither in peripheral blood nor in lymph node tissue. So that means that its detection, otherwise its ectopic detection outside the intestine, indicates the presence of intestinal tissue. In our case, this will indicate metastasis. We used the method, we did this by two methods, conventional PCR and real-time PCR. We used the cybergreen dye in real-time PCR. Maybe some of us know about cybergreen. It is a fluorescent dye that intercalates between any double-stranded DNA, as you can see, and once it intercalates, it fluoresces and it gives a signal. As PCR takes place and amplification proceeds in the experiment, we get more double-stranded DNA segments and more fluorescent dye will be intercalated in between, and this will give me another segment, another signal of fluorescence, and so on, and this will detect amplification in real time. Regarding the results we have, this is a figure of the conventional PCR arrows showing, I'm sorry because the pointer doesn't work, here we can see different intensities of 313 base pair, which is the cytokeratin detected here, compared to the positive and the negative control. We had a patients group of 34 patients, and they were all suffering from colorectal carcinoma. We had two control groups, a pathological control group which was patients with chronic ulcerative colitis, and a healthy control group which were patients only admitted for pelvic repair after rectal prolapse. All three groups were subjected to the routine laboratory investigations in addition to tumor markers. RT-PCR was performed in the peripheral blood of all three groups, and it was not detected actually in any of the three groups. Then we proceeded to RT-PCR for cytokeratin 20 as well in the lymph nodes of the three groups. In the colorectal cancer group, they were detected in 16 out of the 34 patients we have were positive for cytokeratin 20 by conventional PCR. None of the control groups were positive lymph nodes by conventional PCR. When we performed real-time PCR using cybergreen in the patients group on their lymph nodes, we ended up with an extra 4 patients detected, which makes up 20 out of 34. Here we can see that on analyzing these data, we had a statistically significant results here comparing real-time PCR to conventional PCR in the detection of metastasis. Here we can see 16 out of 34 versus 20 out of 34. Also, on comparing different Duke stages, which is the staging system for cancer colon, we also had a highly significant result by comparing the detection over 90% in B2 stage, which is a more advanced stage than the B1. Also, on comparing different histological tumor grades, we had 100% detection of CK20 in poorly differentiated histological grade, which is of course more advanced than the moderately and the well-differentiated. This brings us to a conclusion that real-time PCR provides a more sensitive and reliable technique for quantitation of metastatic cells in colorectal carcinoma. It can be considered a marker for monitoring early metastasis or micrometastasis, and it can also be a predictor of more advanced disease or a bad prognosis in cancer colon. Thank you very much for your attention.